Brad, what do you think? What about what new therapies are you thinking about in mantle cell lymphoma? We have Zanabrutinib also, right? We talked about it a little bit in CLL. Do you see that being used in mantle cell lymphoma? Any reason to go for that versus one of the others? Or?
Hard to say right now. There's a little bit of data for Zanabrutinib in mantle cell. It looks roughly comparable, to acalabrutinib and ibrutinib. So whether it's has some therapeutic advantage over the earlier BTK inhibitors, I honestly can't tell yet. I'm glad to see Zanabrutinib be developed. It'll be great to see more mature, larger data sets. And, it's always good to have options. I'll never complain about having too many choices. But as Matt mentioned, a real problem is just the development of BTK resistance in mantle cell. And so combination studies are very logical, and the venetoclax BTK inhibitors are a very good combination to study, and there's a little bit of experience there. I've seen studies combining CDK inhibitors with BTK inhibitors, proteasome inhibitors with BTK inhibitors, and these are all important studies that are currently underway and will probably have results in the next year or two to help us know if, doublets or triplets of novel targeted agents are better than just single BTK inhibition.
We didn't talk about, we sort of skipped over some of the older agents, right? We didn't talk about bortezomib. We didn't talk about lenalidomide in this. Where are you using those agents? Are you using them?
Sure. Lenalidomide is very useful in mantle cell lymphoma. It's a very interesting drug. The response rates are not terribly high to single agent lenalidomide in the 30 to 40% range, but if you combine it with rituximab, you can bump that up into the 50 or 60% range. And some of those responses can be quite durable. So I do find lenalidomide to be a very useful option for relapsed mantle cell lymphoma. Bortezomib is another pretty good option, not quite as attractive as lenalidomide or BTK inhibition because the response rate aren't quite as high, the durability isn't quite as good, and then there's the whole issue of peripheral neuropathy. But it is another good tool to have in your toolbox. And with mantle cell lymphoma and the way patients start to become resistant to therapies, you can burn through your options fairly quickly, and so there still is a huge unmet need in mantle cell lymphoma for more and better options for the relapsed refractory patient.
What about the frontline patients, John? There was data that published in the New England Journal a number of years ago about a group of patients who were treated with lenalidomide and rituximab in the frontline setting in mantle cell lymphoma. I don't think of it as being like the most standard approach. But there's probably a subset of patients that have, more indolent disease, and maybe they are the right people.
Right. I think that R squared, as we call it, Revlimid and rituximab in the frontline setting for patients who are older, in particular, and that's the study that really you're alluding to, is a quite impressive option for these patients. So if you take patients with mantle cell that are above the age of 65 who aren't good candidates for chemoimmunotherapy, I think R squared is a very appealing approach. The response rates there were, of course, they're treatment naive patients, but were quite good. And the CR rates were actually quite good as well. You could argue over time that might become a preferred regimen for all patients in the front line. We don't have data for that clearly. We need to see more of that. But I'm excited about R squared in the front line for the right patients. But one of the things that we haven't mentioned is we've got to be figuring out a better way to treat patients with TP53 mutations in mantle cell. And so if you have a frontline patient with one of those mutations, this is a whole different story. And those are people that I'm starting to really thinking about CAR T-cell treatments, which is another new approach that we have to keep in mind. There's emerging data that shows that CAR T-cells can provide significant long-term survival advantage, perhaps for very aggressive relapsed mantle cell patients. So I like R squared in the front line in the right patients. I like the idea of BTK inhibition as well in relapsed patients. I think in subsets of patients, in particular with TP53 mutations, we have to consider about more aggressive cellular therapies as well.
Yeah, so you outlined a nice sequence there about potential for cellular therapy as perhaps as third line of people for those patients that need it.